So, continuing my presentations and videos for the Mrcp cases, and now mainly I'm focusing on the cardiology station. So, uh, today let's talk a bit about the case of PDA or patent ductus arteriosus. Sometimes on the basis examination you come across this type of patient. So, how you will present your case? So, once you've done the examination, you can say, give your diagnosis first. This is a very good idea, so that the examiner knows that exactly what you're talking about. So say the patient has patent ductus arteriosus and I was able to appreciate continuous murmur which is loudest in systole and it is loudest in the pulmonary area. Um, tell the examiner about the radiation, that murmurs radiate to the back and it's loudest over left scapula, and always mention important negatives. There is no evidence of any peripheral stigmata of cardiovascular disease. There is no collapsing pulse, no heaves, thrills, or the murmurs. Why you want to mention about the collapsing pulse? Because if there is a collapsing pulse, it means it is severe patent ductus arteriosus. Naturally, the next thing the examiner will ask you how you will evaluate the patient. So tell them, I like to take a full history, because usually, especially the history about any abnormalities or at birth and any family history of congenital heart disease. We like to do the blood test to look for the, especially looking for the inflammatory markers, and 3 sets of blood culture because we want to exclude the infective endocarditis. We like to do the ECG and like to do the echocardiography. And in echocardiography, I want to look at the pulmonary pressure, which could be raised, dilated pulmonary arteries, right ventricular dilatation, and tricuspid regurgitation, and left ventricular dysfunction. So as this murmur is loudest in the pulmonary area, so sometimes it's difficult to differentiate from the pulmonary stenosis, but there are some differentiating points, and this is also a common questions in the PACES exam is how you differentiate a murmur of the pulmonary stenosis and the PDA. So PDA murmur is usually, remember, it is loudest in expiration, and pulmonary stenosis is loudest in inspiration, and murmur of the PDA tends to radiate to the back and is loudest over the left scapula. Pulmonary stenosis murmur can also radiate to center of the back and usually it radiates to the shoulders. So these are the 2 points which you must mention, that how you differentiate a murmur of the pulmonary stenosis and patent ductus arteriosus. Examiner may ask you about the severity, how you know that this is a severe patent ductus arteriosus. So severity, if the patient is severe, they have a collapsing pulse, they may have a right ventricular heave, they may have a left ventricular failure. So why the murmur is louder in inspiration? So what happens at inspiration, that there is increased venous return. So there is more flow across the right side walls. So there is increased severity and character of murmur. So examiner may ask you why you this, so you must answer that this is the mechanism why the right-sided murmur are loudest in inspiration, because of the more flow across the right side walls, and it happens because of the increased venous return in inspiration. So some basic knowledge about the ductus arteriosus. So it's a connection between the left pulmonary artery and descending aorta, and just distal to the left subclavian artery. And you know that normally this closes at birth, or sometimes it remains patent. So patent ductus arteriosus, left ventricular volume overload or right ventricular pressure overload causes the closure. There is a device closure which is undertaken percutaneously. So in terms of the management, if the patient has a left ventricular volume overload or right ventricular pressure overload, this is the indication for closure, usually done by the device closure, and usually it is done percutaneously. Investigations, just to review investigation, they can be on the echocardiography, may have left ventricular volume overload, pulmonary artery pressure. We want to look at the pulmonary artery size and right heart dimension. Cardiac MRI and cardiac CT, sometimes it is needed for the investigations, and cardiac catheterization, sometimes it is indicated when pulmonary artery pressure, we see the pulmonary artery pressure is increased on echocardiography. So for the investigation, echo is important, cardiac MR, cardiac CT, and cardiac catheterization sometimes. So indications of closure, if there is a signs of left ventricular volume overload, pulmonary hypertension, but remember that this is a very important point, that the pulmonary artery pressure should be less than 2/3 of the systemic pressure. Then only you go for the closure. If it is high, then you will not go for the closure. Or pulmonary vascular resistance also should be less than 2/3 of the systemic vascular resistance. So after closure, if there is no residual shunt and there is no left ventricular and pulmonary artery pressure, no increase in left ventricular pulmonary artery pressure, in these patients, no regular follow-up needed beyond 6 months. If the patient has either left ventricular dysfunction or residual pulmonary hypertension, then follow-up 1 to 3 years interval depending on the severity. Lastly, I'd like to talk briefly about the murmur of patent ductus arteriosus, and normally it is actually a continuous machinery murmur, and we're going to hear the recording of the continuous machinery murmur of the patent ductus arteriosus. So it is something like this. So you can hear that it is heard throughout systole and diastole. While the murmur of the pulmonary stenosis is actually ejection systolic murmur, so it not be heard in the diastole. And normally it is heard at the pulmonary area and radiate to the bed, especially at the left scapula. So normally whilst you are doing the examination of the bed, as we normally do for the cardiovascular examination, you can detect this murmur. Okay friends, thank you very much, and I think